Good morning. We have a wonderful turnout of people to listen to the talk of Johann Verhulst, who he's our old friend from university, and we're certainly delighted to have him come back and visit with us again. He earned his MD degree from the University of Leuven in Belgium and completed his residency training in psychiatry at the University of Utrecht in Holland. After his return to Belgium, he joined the Department of Brain and Behavior at the University of Leuven. In 1977, he was a visiting assistant professor at the Department of Psychiatry at the University of Washington and was appointed to the regular faculty in 1978. His assignments at the UW included medical director of the Harborview Community Mental Health Center, director of the Interpersonal Clinic, and residency training director. He received several awards for teaching and clinical excellence, including the Gary Tucker Career Education Award in 2006. Dr. Verhulst is a Distinguished Life Fellow of the American Psychiatric Association, a Fellow of the American College of Psychiatrists, and a member of the Group for the Advancement of Psychiatry. Currently, he is an Associate Professor Emeritus who spends most of his time in Bloomington, Indiana, where he is an affiliate faculty member and senior consultant at the Kinsey Institute for Research in Sex, Gender, and Reproduction at Indiana University. Dr. Verhulst.
Thank you, Chef. It's a pleasure to be back at my old stomping grounds of Harborview. Unfortunately, I do not recognize the place, and I don't know what you guys did with my beautiful mental health center at the corner. So, I'm talking today about the Therapeutic Alliance in Medicine and Psychiatry, and actually, this works. Actually, we will be doing three parts. The one would be the alliance in pre-scientific systems of care, like in the old days and in places where there is no scientific medicine. Then the bulk will be on the doctor-patient relationship in scientific medicine. And finally, some thoughts about the Therapeutic Alliance in Psychiatry. Most of what I'm going to say comes from a paper that some friends at the research committee of the GAP, Group for the Advancement of Psychiatry, published just a couple months ago. And so anyway, let's start with a little thought experiment. Imagine that you lived 50,000 years ago. You're part of a band of hunter-gatherers living in a cave somewhere. And one morning, you wake up and you have sweats and chills and you cough and you feel miserable. And there is no way that you're going to go hunting and gathering today. So, being a human person, just like everybody since then to this day, you will ask yourself some questions, because human beings react to events with two basic things that they want. The one is they want to make sense of what happens. And the second is, since we're social animals, we want to know how it's going to affect our relationships and whether there is help available among our colleagues. So, therefore, the questions that everybody has when they're ill are universal medical questions. And so, in order to make sense of things, we say, what's happening to me? Where does it come from? It's an essential part of what we want to know. What will happen next? And what can we do about it? And notice that the answer to these questions actually forms a story. You know, what, where, and that's a story. And it is because humans make sense of the world by making little stories. And that will be an important part of what we talk about today. We are social animals, specially adapted over millions of years to living in social groups. And so the next questions are, who can I trust to help me? Is there an ally among the people? And number two, how will others react? Actually, one of my major competitors is in that band of hunters, and I'm a little afraid that if I don't show up, he may take my place. Now, if I were not very good at hunting and gathering, which is actually true, and if at the same time I had a little entrepreneurial quality, I might think, you know what? I bet I can get away with just staying home here by the campfire and let the others go out, and I'll be the one that when there are sick people, I'll give them the explanation as to what's wrong with them, and I'll take care of them. And if I was the first to do that, that would have made me the father of medicine. The question we are asking, of course, is the healer that develops in all countries and all cultures at all times, is it the patient's ally? And so let's first look at the definition of alliance. An alliance is a collaborative association to advance common interests or causes. And indeed, healers and patients have common interests. The patient wants answers and help, and the healer is in the business of providing it. So the healer-patient alliance, collaborative association to implement treatment and to make sense of the health condition. Were they really healers? Yes, but it's a little different than how we see the alliance in modern medicine. On the one hand, that they are allies is implied by the healer's role in society. If healers were not to behave like the ally of the patient, they would be out of business quite quickly. As to how did they collaborate, they mostly collaborated by performing culturally sanctioned roles. The healer diagnoses and performs rituals, and the patient undergoes them. And most healers, in most cultures, through a process of like trial and error, discovered that if they could present themselves as having real, secret, magical powers, and if they then could do impressive, awe-inspiring rituals, it worked better. And so the next question becomes, how effective were they? Because there was not a lot of evidence-based medicine at these times, and so most of the therapeutic effect was the result of that interaction between the caregiver, the healer. By the way, every time I say doctor here, you can substitute caregivers because it is broader than just physicians. But so the effect, if it has any effect, is the result of the interaction between caregiver and patient. And that effect is called placebo effect. And so in the paper that I was talking about, there is quite an extensive review of the literature about it and the controversies about placebo effects. But the upshot is basically that placebo can reduce symptoms by 20 to 40%, and that includes everything, including Alzheimer's disease. It improves the level of functioning, and it improves the quality of the patient's life. And so one can conclude that the history of medicine is basically the history of placebo. Now, if you look at placebo, there has been, particularly in the last 10, 20 years, a lot of research done, and the psychosocial research has focused on what are the determinants of the placebo response? And again, there's lots of literature summarizing always 3 determinants come up. Number 1 is that the intervention changes the patient's emotional state. Patient comes with fear, worries, thinks they're going to die, they don't know what's wrong, and at the same time, at the end of the intervention, it's replaced with confidence and hope and trust. Second is that the intervention creates a positive expectancy. If the patient thinks he or she is going to get better, they're more likely to get better. And the third is that if the patient has had previous experiences with the healer that worked well, or even witnessed others getting better, that creates an unconscious conditioning effect, which has been shown to increase the placebo effect. Neuroscience people, particularly in the last 5 years, have studied the mechanisms of the placebo. And again, lots of research, I give you the upshot, and it is that the interaction with a trusted healer activates innate, natural regulatory systems. And those include endogenous opioids release, endogenous cannabinoids release, changes in central nervous system, autonomic nervous system, immune and endocrine systems. So the Healer-Patient Alliance is a treatment for all kinds of illnesses, and it has been with us since the dawn of times. So let's now take the major part, which is the doctor-patient relationship in modern scientific medicine. Scientific medicine actually started around the middle of the 19th century. But the pattern of relationship with the doctor was still very much the same till after World War II. And it has a reason. In World War II, or because of World War II, people really got impressed by the horrors of authoritarianism. And in medicine, there was quite a reaction to the Nazi doctors' trials at Nuremberg, or in the United States, the syphilis experiments at Tuskegee and all that. So all that set in motion, plus philosophical trends and so on, set in motion a trend towards patient empowerment. Now patients can ask questions and make treatment decisions. And particularly in recent times, that has been enhanced by the fact that every patient can first go and Google their problems and get a lot of additional information, which stimulates that patient empowerment part. And the doctors are required and responsible to obtain informed consent, which was unthinkable in a way before World War II, by the way. So given the fact that the patient now expects clear and truthful answers before giving informed consent, then the purpose of the alliance becomes more specific. It is to work together to develop an understanding of the patient's condition and of the treatment plan, together shared between doctor and patient, not just one way, and with active participation of the patient in all aspects of treatment. Once doctor and patient have achieved that kind of shared understanding of the condition and its treatment, they both experience a sense of being in tune, being on the same page, being in full agreement. And that leads us to the concept of concordance. It's a term that's proposed to refer to interpersonal interactions in which both partners subjectively experience that they are in tune with one another. If you look at this definition, psychologists would recoil, because how the hell can you study this extremely subjective thing? It helps a little bit that it's a definition that addresses the interaction. So at least you need agreement between two subjective experiences before you can talk about concordance. That helps. And I did a couple of pilot studies, if you want, not even studies, but I would have an interview done and 4 or 5 residents watching the interview, and then rate on a 5-point scale between discordant and concordance the interview. And it is amazing how people agree on it, particularly on certain things. They agree on moments where there is discordance. People pick that up like nothing. Moments where there is concordance, less so, except if they're exceptional. There is that sense of connection, you know. They were also very good at the end to rate the interview as a whole. It's not scientific, but at least it's an indication. So, to establish an effective alliance, the physician must pursue concordance with regard, particularly those 4 questions. What? Where does it come from? Where does it go? What are we going to do about it? Okay, there are some qualities of the communication that facilitate concordance. And the first one is compatibility. Compatibility is actually defined as having, it's a very broad term, it is having similar information processing systems. A little bit like you can't very well run an Apple program on a Microsoft operating system. The information processing systems don't fit. If I were to talk to you today in Flemish, there would be discordance and a lot of booing and hissing, I'm afraid. But it's not just language in that sense. But if the doctor talks from professional language and you talk to a Boeing worker, there is discordance in the language that you use. There is a lack of compatibility. Compatibility of culture, the doctor has to pay attention to that, we know that. And the compatibility of the emotional information processing systems. If you talk to a borderline patient, that patient tends to have a different emotional information processing and response system. And that's a compatibility problem that you have to overcome. And we all have had the experience that you talk to a patient and you use a very innocuous, neutral statement, and the patient gets very angry or bursts out crying. It means there is differences, there is incompatibility in the information processing system. Same with attribution of meaning, and so the doctor constantly has to make adjustments for compatibility problems. The rest is simple. Transparency means being clear and monitor the patient's understanding and being truthful, of course. Equality is you want to treat the patient like a human being, like one of our kind. And that's why we always have to be courteous and professional and friendly. And empathy means the empathic listening and identifying, which is kind of trying to imagine what goes on in the patient's mind by putting oneself in the patient's shoes. The whole question is, does a therapeutic alliance, defined as it is here, does it have any effect on patients' outcomes? And number one is, I believe that one can make a strong case that it will have a placebo effect, because it fulfills the main determinants of the placebo effect. There is the emotional change. If you have a physician that you're really in tune with, your feelings of worry and anxiety are replaced with more trust and hope. And you have a positive expectancy. With this doctor, I'm sure we can get through our problems together. And if you have seen the doctor before and been pleased, there is a positive conditioning. There have been lots of studies done trying to see whether a good doctor-patient relationship affects outcome. Almost all of those studies have been done by looking at physicians who are warm, friendly, and empathic, and see whether they have better outcomes. And the results are that yes, a warm, friendly, empathic physician has increased patient satisfaction. They adhere more to treatment. They are more motivated to follow his advice about lifestyle. And the risk of being sued is decreased. When they looked at clinical outcomes, there was a positive effect, but it wasn't that strong. And my hypothesis is that it is because it only looked at the physician's attitude, regardless of whether the patient welcomed it or not. And so I think that, or my hypothesis would be, that the Concordant Medical Alliance does both. Both provide the full placebo effect and also the benefits of the doctor-patient relationship. There are two parts to concordance in the alliance. On the one hand, we need to agree, patient and doctor need to agree on the purpose of the alliance, which is to form this shared story of understanding of the illness, right? That's one part. But the other part is that we need to also agree on how are we going to collaborate? What type of a relationship are we going to have that allows us to pursue that goal? So I'll have to talk about both aspects. Here is then a full definition of the medical alliance, and what's added is simple, that it happens through an ongoing process of developing narrative and relational concordance. First, a couple of words then about developing narrative concordance. When a patient feels sick, they may or they may not talk to their family members, they may or they may not go to the computer and Google their symptoms, but whether they do that or not, being human beings, we will form some explanatory hypothesis in our minds, which can be an anxious one. I hope this isn't the same as what Aunt Martha had, you know? But that's an explanatory hypothesis. You go to the doctor, he has a fund of knowledge, does an exam, and therefore gets a medical hypothesis. Even if it's still at the hypothesis state, it's a hypothesis. And so then the question becomes, if you want to get to a joint narrative, how do you reconcile that? Most of us do that by giving information. But giving information is problematic because the meaning of information is very idiosyncratic. It depends on memories and associations and your past and feelings and all that. And the same diagnosis can give unrealistic hope in one patient and anxious despair in another. So it's not just enough to transmit information. Instead of one-way transmission, what we need is a conversation in which the physician takes into account the patient's own hypotheses, takes into account the health literacy of the patient, and of course also the patient's emotional state, and then helps the patient understand what the diagnosis is and what that means, what we know and don't know about the etiology, the story of the etiology, what the prognosis is, and what the possibilities and limitations for treatment are. Of course, this happens in the beginning before you start treatment, and that's important. We've all seen patients not complying with anything you say, and often it is because there was no joint shared narrative that explained things before the patient left. But it's an ongoing process throughout treatment. A couple of special issues. Sometimes one of the partners is not really a valid ally. You see, everybody has a lot of healthy motivations, the motivations to be healthy. But we all have self-destructive and unhealthy motivations. And for whatever reason, one can be overwhelmed by one's unhealthy motivation. And what you then present to the doctor is an unhealthy self. Think of the patient who is identified with the illness, bitter, and the only thing he or she wants is getting some benzos and opioids so that I can forget about the whole world. That's not a valid ally for the physician. Similarly, in psychiatry, a patient can be so overwhelmed by depression and suicidal ideation, or by hallucinations and delusions, that who presents is not a valid ally. And I think it's important to recognize, and I found it very useful, not always, doesn't work always, but to bring that up directly, that I am the ally of their healthy side, not of the unhealthy side. And that's where I will try to put in my efforts. The doctor too can be an invalid ally. If you have a doctor who is burned out, who just goes through the routines but doesn't care very much about the patient anymore, that's not really a valid alliance. And the patient misses out on the benefits and outcome benefits of an alliance. Another special issue is just a detail, but to draw attention to the words we all use when talking to people. Words that are like, they have connotations that make a story. They're like metaphors for stories. Like the best example would be if you use the word disease, or in psychiatry, a chemical imbalance in the brain. You know, those words suggest that this is something that happened to the patient. The patient has nothing to do with it. It's just, a malfunction. They're not responsible for it. They can't do anything about it. You're powerless to diseases. And the only thing you can do is try to find the best doctor who can treat it, because treatment comes from the outside. Those are very common connotations with disease. And for some patients, those connotations are anti-therapeutic. Another word is impairment. Impairment is for most people a defect that you either have constitutionally or after an illness or a trauma or anything else in the past, and you're not responsible for the defect, but a defect means you're responsible for trying to learn to live with it. Again, a word that has connotations that's sometimes very helpful for people in terms of how they think about their condition. And the matter that it is learning to live with it is a challenge, and it can improve your life. Stress is another word that we use all the time. Stress is a great one. It says it's not your fault, it's the stress. but it's actually a bit your fault because you were not able to cope with it. So it's always stress vulnerability, and one has to explore what it means to the patient. We could go on. One of the most mysterious words is the word disorder, that, to my knowledge, most people see either as disease or as impairment. It's not always therapeutic. So we need to use words that suggest something that's therapeutic and not just avoid things that are not all that therapeutic. I had some examples, but my time doesn't allow me, but maybe at the end we can come back to it. This just summarizes it. Every patient deserves the chance to a narrative formulation that's comprehensive, meaning doesn't avoid talking about any of the 4 questions. It's accurate, therapeutic in a language that does good things, and concordance makes sense to both. So that's for narrative concordance. Let's now look at relational concordance. There are 3 elements to it that are of particular interest. One is, what type of relationship do we want? Is it a paternalistic, egalitarian relationship? What do we want? Number 2 is, to what degree is our relationship going to be functional or intimate? Functional means neutral, objective, focusing on the task at hand, and emotionally detached. When I go to the baker, I put down some dollars and I get the bread. That's functional. Okay? Intimate means there is self-disclosure involved. I can talk about my feelings, my values, my past, personal issues. That's intimate. And most relationships are and shift a little bit between those 2 poles. The third one is about the boundaries of a relationship, and one can define boundaries as what sort of behaviors and topics of discussions belong in this relationship, and what sort of behaviors do not belong in it. That is the boundary. Okay? So when it comes to type of relationship, one of the concepts that is rather useful comes from sociology and is the concept of social scripts. And I'll give you the definition. It is an internalized interactional sequence for various interpersonal situations. What that means is that when you drive home and you're stopped by a policeman, for instance, there is kind of a script of how the citizen behaves in a situation like that. And there is a clear script for the policeman of how he or she should behave. And when you were to strongly deviating from the script, you may end up in jail. But it goes for all sorts of relationships, whether it is going to the hairdresser or talking to your boss or going to a medical consultation. It's all kind of, we have scripts for those, and they make the interaction much more easy. You don't have to figure it all out de novo, as the lawyers say. So the paternalistic script is one in which you have a benign authority and a patient who is deferential and submissive. And we still have many of our fellows and our colleagues who kind of like that script and engage in it. And if you engage in it, that induces in the patient a tendency to respond similarly, but they may not like it. But some patients also are quite comfortable with traditional authoritarian scripts, and so they act in terms of that script. When they act in terms of that script, it induces in you a tendency to respond with benevolent authority. If you do that, You have concordance. The only problem is it's concordance where the informed consent is questionable and it can be dangerous. So we try to steer a little bit towards more equality by treating the patient with extra respect, for instance, and validating him. What's important is that if the patient really only feels comfortable in a somewhat submissive script, you cannot force egalitarianism on them. That makes the relationship discordant and you lose all the benefits and the patient may resign it. Somewhat different is to steer the patient gradually towards more equality. Recently coming very much en vogue is the partnership of experts. It's patients usually with a somewhat chronic illness. They've read everything about it. They went to Google Scholar and read the last articles. They have lived the illness, so they consider themselves the experts on their illness and want to be treated by the physician as a co-expert. Many of us don't like that very much. They can be very challenging patients, and so you can find on the list, on the web, lists of doctors that are considered e-pt-receptive physicians, where you can have a concordant relationship between them. Most of us are more comfortable with the egalitarian script, where yes, the doctor is an authority in the sense that he has special expertise, but it's balanced by the patient who uses his or her power of refusing treatment if they don't want it. So to reach concordance, one has to be sensitive to what's happening in terms of type of relationship and make adjustments as appropriate. It's much more important to be flexible than to be good in one type only. Functional versus intimate, I just have a couple of possibilities. Suppose the patient likes the intimate dimension, prefers it, prefers personal interaction and sharing of feelings. If the doctor fully reciprocates and also shares experiences and feelings, that is an interaction that tends to be bonding. That is what we do during courting. We start exchanging personal information. That is not building an alliance. On the other hand, within that same category, if the patient is self-disclosing and the doctor responds with empathic statements, that has a positive therapeutic effect. Many patients, I don't know why, but it seems particularly in psychiatry, they like very functional interaction. I don't want to talk about myself, doctor. I just want you to take care of it. Don't ask all these personal questions. If the doctor agrees and also likes very functional interactions, there is concordance, but it's quite an impoverished relationship because the patient may need at some points emotional support and it's not going to be there. And the doctor may need personal information and it's not going to be accessible. So it's an impoverished but concordant relationship. If the physician, if the patient wants a functional relationship, and what happens quite commonly, the doctor keeps pressing for a more personal, intimate one by being very friendly and warm and empathic. Usually it comes across to the patient as false, and it's discordant, because the patient feels, here is this very empathic guy, but he doesn't seem to pick up on the fact that I want a functional relationship. What sort of empathy is that? It must be in his interest, not in mine. Again, The point is about flexibility in steering the interactions. Boundaries, what sort of behaviors belong there? It leads to a very simple rule of ethics, which is all interactions with the patients must serve the agreed upon goals of the alliance. And so if you treat family members and friends, the alliance may be hindered by the fact that you have a competing relationship. And more importantly, if you were to pursue personal goals and make that a priority, that doesn't work for an alliance, because alliance is based on common goals. And so if you pursue a romantic relationship, you betray the alliance. If you're into status and money, and if that is the main one, that detracts from an alliance. Even the pursuit of warm, empathic connections can detract from the alliance. I remember in the good old days supervising our 3 residents who would begin their psychotherapy long-term training, and they would at some point discover that wonderful sense of empathic connection with the patient, which is really very nice. And then in subsequent interviews, both patient and therapist would try to recreate that feeling. But therapy is not about sitting together feeling great. Therapy is about change. So the goals of the alliance are not there. Another thing that's quite common is that when a patient suffers, we respond with compassion, with support, with advocacy. But if that starts taking over, when what we do is being the supportive, compassionate, advocating person, we may lose sight of the goals of the alliance, which are different. And then we call the caregiver in question over-involved, and they need to refocus on what the goals of the alliance are. A question is, does establishing concordance require extraordinary communication skills? Well, actually not that much, because humans have a social brain. Our brain is literally the residue, or much of our brain is literally the residue of millions of years of social interactions as we adapted to living in social groups. Further developed from birth on through interactions with others, and actually being changed by interactions, which is why psychotherapy works till this very moment. So we have a natural propensity, shaped throughout life, to tune into others, to deal with misunderstanding, steer the communication, and so on. And by the way, that is why I'm persuaded that one of the big, nice things for a psychiatrist is to come from a somewhat neurotic, dysfunctional family. If you come from a perfect family, you don't have to pay attention to anybody. You can go straight into computer programming. But if you come from a neurotic family, you need to learn to tune into others, to know how to steer it. So we need to all thank our parents for providing us with this opportunity. The communication skills that are involved in learning all this are basically non-verbal. We make these adjustments through tone of voice, facial expressions, posture, all these types of things. And they're guided by emotion, by emotional attunement. And so that's why when a communication is rough, we have that sense that it's rough. That indicates it's discordant. feeling in tune is really a feeling, the feeling that it's smooth. Discordant can give all sorts of things, including getting quite irritated. And of course, some people are more talented than others, and training usually helps. Finally, now, the Therapeutic Alliance in psychiatry. Concordance is a major challenge in psychiatry because we deal with almost all of our patients have somewhat idiosyncratic emotional processing systems. And so there's going to be a compatibility issue, not just borderline personality disorders and psychosis, but, most conditions, they process information. We are very good, by the way, at dealing with that. We're trained to deal with that, which is why I'm going to focus for this last part on the developments in clinical practice and in approach to the diagnosis of the last 50 years, so I lived through it all. Let's look at the need for diagnostic criteria. When I was a resident in the 1960s, when we did a psychiatric interview, it was very clear we had to do two things. The one was we had to identify the syndrome, the illness. We all walked around at the time with, in our program, Bloiler, which kind of was directly Kraepelinian system of diagnosis. But if you live in a small country like Belgium, you get visitors from France all the time. They had a totally different system. And then the Brits would come over, and they had a totally different system. And the Dutch would follow Rumke. And an occasional American visitor seemed different again. In addition, anybody who had 3 cases that looked a little bit similar spent Sunday afternoon writing a paper over a new syndrome. And so what that meant is, regardless what sort of patient you saw, you could always go to the literature and find a syndrome that matched it and impress your attending to no end. But of course, that made talking between psychiatrists and doing research rather difficult. Not only, that was part 1, we had to be able to identify the illness. Part 2 was we had to make a story of understanding of the illness. Not just classify, but understand. And that's an old tradition. Barely after Kraepelin came, Griesinger first and Kraepelin, with their system, you had Jaspers, who tried to use phenomenological techniques to really get into the patient's mind and try to understand what it feels like to be psychotic, what it feels like to be melancholic and all that. But he was quickly overshadowed by a new stream, which was Freud, who was easier to apply because he had a lot of theories that you could easily apply to patients. And so, most in our program, we had to come up with a story of understanding that was usually psychodynamic. A few learning theories were accepted, but it was mostly actually Lacan-type psychodynamics. Because that was the problem. Again, your theories, how you talked about the patient, how you understood the patient, depended on the school you belonged to, the philosophy that you followed, and it was a mess. And nobody could talk to anybody. So it's very clear that we needed a diagnostic system with a goal, not as much to understand, but to have a reliable system. That created a challenge to the Alliance, because if you want to develop a narrative formulation, it is more difficult when the focus is on meeting criteria versus understanding the patient. I must say, every time I see a depressed patient, one of my first questions is, suppose I don't know anything about depression. I'm from Mars. How would you describe your depression to me? What does it feel like? And I really feel I get more mileage out of the answers of the patient than by checking criteria. But a more important problem with the DSM, in my opinion, is that it almost completely forecloses etiological assumptions of cause. And yet, we are humans. We cannot avoid making etiological assumptions, both the patients and the physician. If we don't make it explicitly, we have a sense for it. We have a sense for the etiology. Not only unavoidable, but it's also necessary because we needed to make a narrative formulation. And in addition, it's useful because if there is a narrative formulation and the patient can link the treatment to an explanation of what happens, the compliance is going to be much higher. So, another example would be, I used to do board interviews, and for the, I was a board examiner. And when you ask the candidate at the end, give me a formulation, they would always list the 4 P's. But very few would turn predisposing and precipitating factors in a little story of the path to the illness, and the perpetuating and protective factors into a little story of the path of the illness. And I think that's part of our being raised with not enough of causal assumptions, not facts. Second part is, I seem to have my papers not about that. Anyway, because of managed care and also the DSM, the focus now is on structured, efficient psychiatric evaluations. In cost-managed care settings, the psychiatric evaluation consists of an ever-increasing number of specific tasks that have to be documented, performed and documented, and that in the shortest amount of time possible. And I had in my paper, but I seem to have lost them, a list of all the things that are expected in an interview, from establishing a bit of a connection to the patient, to, checking the major categories, whether there are symptoms that the patient endorses, to doing a bit of a history of not only the patient's family and the history of illness and so in as far as it's relevant, but also a medical history, to get to a diagnosis, a treatment plan, and all that, and do all that while at the same time making sure that you document exactly right so that you get paid for what you've been doing. And all that has to be done in an hour. I must say, I'm not very good at it. I've seen colleagues who are masters at it. It's wonderful. They do a fabulous job. It's very sophisticated skills that are required to do this well. But it doesn't allow much of an opportunity for letting the patient's story unfold. And so, to avoid compromising the Therapeutic Alliance by neglecting narratives of understanding, we should provide actually extra time beyond what's needed for the structured interview, because the structured interview is a real serious task. We need extra time so that The psychiatrist can let the patient's story unfold, check a little bit on causal impressions, and construct a narrative story of understanding. This whole talk, which is a concept paper, that's an emergency. You better take care of it. There are several research questions. What is the reliability of assessments of concordance? That needs to be looked at. Does indeed concordance have all these effects on outcomes that I assume it has? What would be good training models? Personally, I believe modeling by attendings is essential. We need to look at whether it's cost effective, and if it's cost effective, we should have an incentive structure, otherwise it will never happen. And so we can wrap up that the Medical Alliance is an essential part of quality medical care. The primary goal is to develop a concordant narrative formulation and treatment plan, which should be documented and paid for. And being an old training director, I have to say that it should be required in the training of doctors and patients. That's it. I leave you with a summarizing slogan. Thank you very much. How are we doing on time? Oh, great.
I just want to comment. I didn't live quite so long in Tunis as you did. I didn't start in the 1800s, but almost. I have to say that I so much agree with much of what you said, and also the current pressures on our nature of practice. In addition to those sort of reality pressures, I also think a major factor was the emergence of the SSRI antidepressants in the late 80s. Because it became so widely and easily used compared to the medications we used before, it accelerated the sense of a recipe checkbox, cross-sectional rather than longitudinal, ideological,
Absolutely.
And I think that I see that in our trainees, that there's, as we move further away from the generation that we both benefited from, as much as there were limitations about psychoanalysis as a delivery model, the theories at least cause us to be thinking about some of the gaps that you're talking about now. How did we get here? What are the determinants? What are the dispositions that continue it? But I really do think that our increasing accessibility to medications actually accentuated part of the problem.
It's a good point, and it probably also introduces that metaphor of it's a chemical imbalance in the brain.
Find the right concoction. And
we don't have to do anything about it. Sorry.
One thing that I think could add to this is the idea that with our current system so reliant on self-report and quick checklists that the clinician does, it kind of assumes that the patient will give you information that's actually correct. And I'm not saying that the patient would be not posing malingering or factitious disorder, but just they might not know what the real problem. They might not be able to accurately describe their interactions simply because of lack of understanding. And I think that this is often overlooked in a lot of the training, is that we think that we'll get all the correct information from people when they're coming to us with a sense that I don't know how to fix myself. If they knew how to fix themselves, they'd never talk to us properly.
And in the beginning of an interview, you want to make a good impression, so you give socially desirable answers, if at all possible. It's a very good point.
thank you, that was wonderful.
Thank you.